Hello, everyone, and welcome to today's live broadcast, Utilizing Available Biomarkers to Tailor and Individualize Therapy in Diabetes, presented by Dr. Ajay Rao. We are excited to bring you this educational webcast presented by LabRoots and sponsored by DiaSorin. DiaSorin is a global leader in the field of technology with a presence in over 80 countries. For over 40 years, DiaSorin has been developing, producing, and commercializing worldwide reagent kits for the in vitro diagnostics market, in particular for the immunodiagnostics and molecular diagnostics segments. DiaSorin's products are specifically designed for hospital and private testing laboratories. Their product menu is unique for its width and presence of specialty tests, which identify DiaSorin as a diagnostic specialist. For more information about our sponsor, visit www.diasorin.com. I'm Julie Simmeroth of LabRoots, and I'll be your moderator for today's event. Before we begin, I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. Just click on the green Q&A button located in the lower left of the presentation window and type your question in the box that appears on the screen. We'll answer as many questions as we have time for at the end of the presentation. Also, please notice that you will be viewing the presentation in the slide window. To enlarge the window, just click on the screen icon located in the lower right. If you have trouble seeing or hearing the presentation, please click on the support button at the top right of the presentation window, or use the Q&A button to let us know that you're having a problem. This is an educational webinar and thus offers free continuing education credits. After the webinar is over, please click on the CE button located in the bottom left-hand corner of your webpage and follow the process of obtaining your credits. Now I'd like to introduce Dr. Ajay Rao. Dr. Rao is a board-certified endocrinologist specializing in diabetes and cardiovascular disease at the Lewis Katz School of Medicine at Temple University in Philadelphia, Pennsylvania. Dr. Rao completed his internal medicine residency training at the Leahy Clinical Medical Center in Burlington, Massachusetts, and followed this with a 2-year clinical endocrinology fellowship at the Tulane University Health Sciences Center in New Orleans, Louisiana, where he was involved in landmark clinical trials in diabetes such as ACCORD and Tinsel T2D. He also went through a critical care fellowship at the University of Pittsburgh Medical Center in Pittsburgh, Pennsylvania, before finishing a 3-year research fellowship at the Brigham and Women's Hospital, Harvard Medical School in Boston, Massachusetts. Dr. Rao also received a master's in medical sciences from the Harvard Medical School. His clinical expertise is in diabetes and cardiovascular disease and has research interests in diabetes and residual cardiovascular risk. Please join me in welcoming Dr. Ajay Rao. I will now turn the presentation over to him.
Thanks, Julie, for that kind introduction, and welcome everybody to this webinar really pertaining to utilizing available biomarkers to tailor and individualize therapy in diabetes. I'm a clinician. I see many patients with diabetes and have a particular interest in cardiovascular risk reduction in these patients. And I hope that with this talk, we'll all be able to better manage these patients and help them prevent complications. I have no disclosures pertaining to this particular presentation. However, I do receive research support from Novo Nordisk. So briefly, to provide an overview, the objectives of this talk is to really understand the epidemiology of type 1 and type 2 diabetes. I would also like to hopefully glean on the complexities involved in distinguishing type 1 from type 2 diabetes in the modern day clinical setting. And hopefully finally we'll understand the role of utilizing the available biomarkers in order to tailor therapy in diabetes. So clearly, diabetes is a growing phenomenon across the world. This is a graph from the United States CDC Division of Diabetes Translation, which clearly shows the inflection of diagnosed diabetes and percentage of individuals with diabetes. And as you can see, we've had a marked increase over the last 15 to 20 years. Many people have wondered if this has been related to the way we diagnose diabetes. Earlier approaches to diagnosing diabetes involved letting individual sugars get up quite high before we actually formally diagnose them with diabetes. However, more recent criteria, which we will go over later in this talk, are a little bit more stringent and are probably detecting individuals at an earlier stage. However, having said all of that, clearly this rise in diagnosed diabetes parallels the epidemic of chronic overnutrition and obesity as it pertains to specifically type 2 diabetes. Now, this has been the phenomena here in the United States, but clearly this is a growing problem across the world, including Southeast Asia, where there's a growing population of diabetes, especially in Chinese and Indian individuals. Similarly, here's a sort of heat map which looks at age-adjusted diabetes prevalence rates in the United States. And as you can see here, clearly there's potentially a regional variation where in the south of the United States, there is a higher prevalence of age-adjusted diabetes. But as you can see here, we have a problem throughout the country. In the west, in the urban areas of the Northeast, in the Midwest, and as you can see also some areas in the Native American subset where there's a really high incidence of diabetes. This heat map could probably be overlaid upon by the rising epidemic of obesity and probably would match the heat map very similarly. This sort of breakdown has been seen across the world, but clearly is, as I mentioned before, a growing problem. So close to probably about now 10% of the United States population, there's a little bit of older data that I'm showing here, has diabetes. The bulk of those individuals have type 2 diabetes. And I think what our concern is that we have many individuals who have diagnosed diabetes, and we are hopefully trying to get these individuals to their goals, to prevent them from having any small vessel or microvascular complications, and also to risk modify their criteria to prevent them from having cardiovascular disease. However, what we're most concerned about here is the individuals who are undiagnosed. These are patients who are walking around and do not know that they have diabetes, and at this stage of their disease, most likely are without symptoms, which makes them even at a higher risk. So we hope to get this population to be diagnosed, and hopefully we've had a lot more of nationwide efforts to screen individuals for diabetes. Hopefully we'll get there sooner than later. Crucial part of treating diabetes is prevention of complications. And this is a slide from a couple of years ago by Greg et al. In the New England Journal of Medicine, where they looked at trends in diabetes-related complications among adults with diabetes for at least the last 20 years. And as you can see here, the data now is from 2010. So I think what can be clearly noted here is that we have had a drop in cardiovascular events. And as you can see here in red, the acute myocardial infarction has clearly gone down over the years. And this can similarly be seen with stroke. And these two entities continue to happen with patients with diabetes, and heart disease remains the #1 cause of death in these patients. Sadly, although we've made a lot of efforts in getting people controlled as it pertains to their glucose control, you still have the same event rate for a known microvascular complication, which is end-stage renal disease. So we clearly need some more efforts to target this population. The drop in acute myocardial infarction and stroke probably has to do more with evidence-based care within those entities, so that the modern approach to an acute myocardial infarction or heart attack has actually become quite refined and optimized, and patients do much better. Further, we have other non-glucose lowering therapies, such as statin therapy or other LDL lowering therapy as it pertains to cholesterol, which has also helped this drop in acute myocardial infarction and probably also stroke. But one thing I want to remind you all is that even after these huge efforts we've made, we still have a pretty high residual cardiovascular risk in these patients. So when we treat our patients with both type 1 and type 2 diabetes, we clearly have the heart in mind. So how do we define diabetes nowadays? And this is a standard classical diagnosis from the World Health Organization from several decades ago, which noted that the definition of diabetes really is a syndrome of disordered metabolism with inappropriate hyperglycemia due to either an absolute deficiency of insulin or reduction in the biologic effectiveness of insulin, or both. And when you closely look at this definition, clearly there is two parts of this. One is the inappropriate hyperglycemia that these patients have, but also that it is related to either an absolute deficiency of insulin, which we typically see in type 1 diabetes, or a reduction in the biologic effectiveness of insulin. So there's two parts of it. It's both the glucose and the insulin. And when we think of type 1 diabetes, or what we used to call juvenile diabetes, we think about an absolute deficiency of insulin. And when we think about type 2 diabetes, we think about reduction in the biologic effectiveness of insulin. But one thing that is very important to remember is that many individuals with type 2 diabetes end up having age-related decline in their ability to make insulin. So these individuals relatively become absolutely deficient. Here are the criteria for a diagnosis of diabetes mellitus. So the first three criteria need to be repeated. So you could either have a fasting plasma glucose greater than or equal to 126 milligrams per deciliter, or 7 millimoles per liter. Fasting is defined as no caloric intake for at least 8 hours. You also could have a 2-hour plasma glucose greater than or equal to 200 during an oral glucose tolerance test. The test should be performed as described by the World Health Organization using a glucose load containing the equivalent of 75 grams anhydrous glucose dissolved in water. And finally, the third criteria, which can be done in the clinical setting, is a A1C greater than or equal to 6.5%. So this is the hemoglobin A1C. The A1C measurement has been verified as being strictly correlated to microvascular complications and had historically been used for a long time for assessing and surveillance of patients with treated diabetes. However, in the last 5 to 10 years, it became part of the diagnostic criteria. And this is great because this allows individuals not to need to be fasting or have to go through an oral glucose load. The one caveat is that the test is still being refined and it needs to be performed in a certified laboratory and in a standardized fashion. The other important feature to remember is that there are individuals who can have variations in their hemoglobin measurements, either because of anemia or other related issues with their blood counts, that could falsely lower their A1C, and then this may not be the ideal test to choose. The key thing to remember for any one of the first 3 tests, you need a repeat of that test. Now, this could be done by repeating the same test, or this could be done by measuring 2 separate tests on one sample. But our hope is that hopefully we're able to detect more of those undiagnosed patients so we can help them better manage their disease. Now, finally, there are patients who present with what we call classic symptoms of elevated sugars, or potentially might be in a crisis mode. So these are people who we might be seeing in the emergency rooms. They may have urgently come into our clinic, or they're already hospitalized. These patients are having classic symptoms of hyperglycemia, that is, urinating a lot, thirsty a lot, and their random glucose is elevated, and those individuals can be diagnosed right then and there because of the classic symptoms and the elevated sugars. So on closer examination of this diagnostic criteria, one can clearly see it is dictated by the circulating glucose level and or a measure of glycemic variability. We are focusing on perturbations on the glucose, and as you can notice here, there's really no commentary about what the circulating insulin levels are, effectiveness is, or if there is deficiency. Here is a slide of the approved anti-diabetic medications in the United States. I placed this slide here just to show that we've had a dramatic increase in the amount of new medications over the last 20 years. But at the same time, you can see that their effectiveness when it comes to their use as a single agent, as it relates to reduction in hemoglobin A1C, may not be thought to be that great. Insulin has been around for a long time, since the early 1920s, and clearly has an ability to reduce A1C by close to 2.5%. Now, when we look at the agents that have been recently approved, it's important to note that most of them will be used in combination with metformin, which is one of the more commonly used first-line agents in type 2 diabetes. But again, the slide here focuses on reduction in average glucose and the importance of potentially utilizing combination therapies. The other thing to note is due to an experience with one diabetic agent, all new diabetic agents that are used in type 2 diabetes, and in fact even various newer insulin formulations, are mandated by not only the United States Food and Drug Administration, but even the European agencies to have a defined cardiovascular outcome study. Mostly because, again, the #1 cause of death in these patients remains cardiovascular disease. And we would like to choose anti-diabetic agents that are safe for the heart. So it's really made it a very interesting arena because clinicians are able to now choose appropriate therapies for their patients. But it also makes it much more complex because we want to make sure we're choosing the right agents for the right patient. So I've talked a little bit about heart disease in these earlier slides, but clearly there is a well-known link between diabetes and cardiovascular disease. When we have classically thought of the metabolic syndrome, we think of individuals who are in these obese, hypertensive, dyslipidemic patients who have this collection that is known as the metabolic syndrome and are at high risk for cardiovascular disease. Clearly, there are also probably inputs in from other entities, such as stroke, peripheral artery disease, and from these outcome trials of newer agents as it pertains to diabetes, specifically type 2 diabetes, we've learned a lot more about the relationship of heart failure and type 2 diabetes, and that this might be something that we need to ask our patients more about, as that might be a predictor of future events. In addition, patients may have perturbations of their rhythm, so they could have heart rhythm, so they could have disturbances such as atrial fibrillation, and this can lead to things such as stroke in the future. So clearly, diabetics are at higher risk for cardiovascular disease, probably mediated a lot through obesity, hypertension, and dyslipidemia, but also newer markers. So what is a biomarker? We utilize these as clinicians to help our patients. We assess these in clinical studies. We review the effects of biomarkers in a variety of research settings. So classically defined, a biomarker is a characteristic that is objectively measured and evaluated as an indicator of normal biological processes, pathogenic processes, or pharmacologic responses to a therapeutic intervention. So clearly for us here in diabetes, we are looking for a biomarker that correlates well with not only pathogenic processes, but probably also how an individual responds to a pharmacological therapy. So what are the available biomarkers that we have? What are the tools that we use currently? So two tools that are well tested and have been utilized in the clinical setting for a long time include the urine microalbumin to creatinine ratio. This is the measurement of protein excretion from the kidney and from urine. Gives us an idea of potentially early damage in diabetes. And also, as I mentioned before, the A1C. So A1C not only utilized for diagnostic criteria, but it also can have a lot of benefit when it comes to monitoring patients, and is a good predictor of outcomes in these patients, not only small vessel or microvascular outcomes, but probably also large vessel or macrovascular outcomes. So these are well-tested biomarkers, so they should have probably high level of evidence when you look at the established guidelines. So here is the urine microalbumin to creatinine ratio and the statement that the American Diabetes Association makes on this. So in individuals who are non-pregnant, who have diabetes and hypertension, either an angiotensin converting enzyme inhibitor or an angiotensin receptor blocker is recommended for those with modestly elevated urinary albumin excretion. That's a level B evidence, and strongly recommended for patients with urinary albumin excretion greater than or equal to 300 milligrams per gram creatinine and or an estimated GFR less than 60. So you can clearly see there that's a level A evidence. So pretty robust data to back the utilization of those agents for hypertension management or proteinuria management. So we talk about this as a biomarker. How is it helpful as we gauge these patients' response to therapy? So interestingly, if you look at the American Diabetes Association statement about monitoring patients, they mention that continuing monitoring of the urinary albumin to creatinine ratio in patients who already have known albuminuria on an ACE inhibitor or an ARB is reasonable to assess treatment response and progression of diabetic kidney disease. Now, sadly, this is a level E evidence, almost expert-only evidence. And the problem with this is that in non-diabetic and diabetic subjects, microalbuminuria is associated with an increased cardiovascular risk. And the key thing here is that it is independent of known risk determinants. So a very well-reputable biomarker has had issues when it comes to utilizing it in surveillance or managing therapeutic response. So we tried to tease out this a little bit in a small study that we did several years ago, where we tried to check another urinary marker which may be more related to pathophysiological processes that are underlying. Here, we actually assessed urinary aldosterone. And we did this in individuals who had well-controlled type 2 diabetes and on appropriate lipid-lowering therapy, and most importantly, appropriate renin-angiotensin aldosterone system blockade. So, like I alluded to before, either an ACE inhibitor or an angiotensin receptor blocker. And as you can see here, what we did is we actually assessed urinary aldosterone measurements on the x-axis in a 24-hour urine collection. And we also had the ability to measure non-invasively cardiac fibrosis. And this is on the y-axis, the myocardial extracellular volume, which is a measurement, a non-invasive measurement of cardiac fibrosis. And you may ask why cardiac fibrosis is important. Well, it probably is one of the key features of the early process of the diabetic cardiomyopathy or the diabetic heart disease. And it clearly has a relationship for many preclinical studies with the hormone aldosterone. I think what's important to note here is that these individuals were already on ACE inhibition maximally, and they still had excursions of their urinary aldosterone measurements, and that these correlated with the fibrosis in these patients. Now, the R statistic may not be robust here, because clearly we know that there are many other things that go into the variability of fibrosis in a particular human, but still pretty important to note that there was a statistically significant correlation of this biomarker. Another thing to recognize here is those individuals with even undetectable urinary aldosterone levels at baseline may have had problems with fibrosis, even with no excess aldosterone in the circulation. So clearly, we probably need additional biomarkers to assist in prevention of proteinuric disease, which clearly has an association with cardiovascular outcomes. Another way of looking at this, we divided the 24-hour urine aldosterone measurement into either greater than or equal to median aldosterone levels in the urine versus less than median. And as you can see here, those individuals who had higher than or equal to median values for their aldosterone levels clearly had higher cardiac fibrosis as measured by the extracellular volume that we again did non-invasively, and this was statistically significant. So again, is that an appropriate biomarker of the urine microalbumin to creatinine ratio? Could we use urinary aldosterone as a perhaps better marker, as it probably correlates more with the underlying pathogenic process? Now, this could be similar even if you look at the other end of the spectrum, which is regulation of glucose and insulin metabolism. You would assume that it would be nice to measure the actual hormone that's involved in the disease, such as insulin. So here is a simple study, pretty old study from Quebec, Canada, where they actually investigated odds ratios for heart disease according to plasma insulin concentrations. So what I want to mention here is that the x-axis here is completely related to the insulin levels, and those are split up into 3 levels. And then the covariates here are known cardiovascular risk factors, at least at the time and probably still today, various measures of cholesterol, and also various measures of remnant lipoproteins or remnant cholesterol, which probably have a physiological significance as it relates to damage to the cardiovascular system. And as you can see here in the tertiles of insulin levels, the higher tertile clearly had the higher odds ratio for cardiovascular disease, really irrespective of where they stood when it came to known cardiovascular risk factors. So you would assume that this might be something very important to the clinician to assess. Yet, when you look at the available guidelines from the American Diabetes Association, clearly we are focused on glucose lowering. And if you look at this slide, there is clear dictate from the ADA to consider therapy based on what their level of sugar is. So essentially, what the patient comes in with will dictate sort of the choice of therapy. So here, you are going to start monotherapy unless their sugar is clearly elevated with most likely an oral agent. Here we're specifically focusing on type 2 diabetes. And then you will move on to dual therapy or even triple therapy with oral agents in individuals who have higher sugar levels. And there's no individualization dictated here in the therapy. And a lot of this has to do with the concept that we spent almost 2 to 3 decades making sure that patients were treated to target. And I think that's the focus of this guideline, which is probably reasonable at a population level. Now, since this guideline is focused here in the United States, there is also a lot of commentary about the cost-benefit ratio. So as you can see here, each agent is given a cost, and also there's commentary on the efficacy, risk for side effects, and risk for, obviously, low sugars, which is something that we definitely want to prevent. Clearly, there's a group of patients where we're going to consider injectable therapy, and here is an algorithm, again, focused on what your glucose level is at the moment and giving you appropriate guidelines for how to start insulin, how to utilize insulin, and how to utilize other injectables as add-on therapies to insulin. And as you can see here, again, there is focus on treating the target, changing therapies based on what the person's level of glucose control is, which is clearly an important thing, but again, has to probably be individualized. So why is this all important? And the reason is that we have a view of diabetes progression to simply, if we think about individuals with either type 1 or type 2 diabetes, there's some type of sort of double hit in these patients. They may be at risk, they may have something else that happens in the midst of this at-risk time period, and they either fall into the categories of type 1 or type 2 diabetes. So if you look at long-standing literature in this field, this is now focusing more on probably type 1 diabetes, you can see that there's individuals who are genetically at risk to begin with, and those individuals are able to compensate with their sugars being at a relatively normal value for some time. And then there's sort of a second precipitating event that occurs, and this clearly causes the perturbations in their glucose levels, and they end up developing diabetes. Now, in type 1 diabetes, there's been a hope that we can capture some of these individuals in this disease setting, hopefully to try to prevent them from having overt beta cell mass loss and prevent them from having overt diabetes. But as you can see here, there's commentary about another way of measuring insulin, endogenous insulin, which is the C-peptide level, whether this is present or not present. And this might be an important feature to consider when we manage patients with diabetes. So what are the differences between type 1 and type 2 diabetes? And are they usually pretty clear-cut? So classically, we've thought of type 1 diabetes as a disease that occurs in young individuals. So we usually used to talk about this as juvenile diabetes. We expect that these patients will have probably a more abrupt presentation as opposed to type 2 diabetes, which might be seen over time. The type 1 individuals may have classic symptoms of polyuria, polydipsia, and are surrogate for their level of insulin resistance has usually been measurement of body weight. Those who are overweight probably have more of a type 2 diabetes picture. Those individuals who are non-obese, similar to probably a type 1 diabetes picture. And in these patients who have type 1 diabetes, they have severe deficiency. They rarely have insulin resistance. The type 1 diabetics clearly need insulin therapy. So that's been our classical viewpoint of distinguishing these two disease entities. But let me just talk about a case to try to maybe shed some light on this topic. So it's a patient that I saw recently, a 52-year-old male, who presented with what his provider had mentioned was quote-unquote brittle diabetes. He was diagnosed 3 years prior to his current visit. His A1C, which is being used here to monitor his control, was around 10.6%. He was started appropriately on an oral agent and titrated up on that agent. He did not have an obese BMI, and when I saw him, his current A1C was 8.7%. So he's had a reasonable response. But the question is here, is type 2 diabetes mellitus the correct diagnosis for this patient? Is there anything else we should be assessing for this patient to determine if we're missing something or the approach should be different? So one thing to remember is in a really minute portion of the population, probably in places where there's a higher prevalence of type 1 diabetes, about close to 10% of adults may have something called latent autoimmune diabetes in adults, also known as LADA. And these individuals will have circulating autoantibodies actually directed against the pancreatic beta cell. So they might have what we call islet cell antibodies or GAD65 antibodies. That's the glutamic acid decarboxylase antibodies. So these are the antibodies that are sort of the villain when it comes to classic type 1 diabetes. But surprisingly, there is a portion of adults who also have these circulating antibodies. And they're adults, they're not children. They don't require insulin at diagnosis, but they progress to insulin dependence or need after several months to years. And perhaps in these patients, the presence and titers of those antibodies could assist us and help us identify patients thought to have traditional type 2 diabetes. So going back to our case, that might be something that we might consider in this patient. And again, that is assessing their antibody levels. If we go back to our algorithm, clearly there's not any commentary about the measurement of GAD antibodies at any sort of level, and not really a discussion about whether and whom we should consider testing to have those antibodies or other measures of insulin secretion. And as you can see here, you may wonder whether it's actually helpful to order insulin levels or helpful to account for insulin secretion by the body, because as I mentioned before, clearly there's a high risk of cardiovascular disease for those individuals with higher circulating insulin levels. So what is the role of assessing insulin secretion? So insulin is produced in the pancreatic beta cell by cleavage of the prohormone precursor proinsulin to produce insulin and C-peptide in equimolar amounts. And this is one of the crucial reasons we utilize C-peptide as a surrogate for insulin secretion, at least from endogenous sources. C-peptide has a longer half-life than insulin in the circulation, and one problem with insulin assays is that the exogenous insulin will be detected by the insulin assay. So if an individual is already on insulin, this makes it challenging to assess their insulin levels. And peripheral insulin levels may not accurately reflect what is really the important feature, which is the liver or portal insulin secretion. And this is even the case even in non-insulin treated patients. So the impact of a given level of insulin secretion will depend on an individual's insulin resistance. So what I'm trying to say is that if a person is already insulin resistant, then additional insulin secretion problems will make management a little bit more difficult and probably should be, again, individualized. Choice of therapy should probably be a bit different. Even in patients who separately have declining insulin secretion, if they have additional insulin resistance, this will cause diabetes to develop earlier. And the final issue here is that obese insulin-resistant patients may have normal or even high C-peptide levels at their presentation, even if they have autoimmune type 1 diabetes that we think is phenotypically type 1 from our available biomarkers. And this is where we've had some difficulty recently because many patients with type 1 diabetes don't present classically with that lean body phenotype. So the C-peptide assay has clearly had recent improvements. It's a non-isotopic assay, so chemiluminescent, fluorescent. There's still problems with optimal standardization, but this has been worked on to a great deal. And the concerning thing, of course, is set factors or set reference ranges for specific populations with diabetes, meaning should a white population or predominantly white population have a different standard range than maybe the Asian subset, and this is still yet to be teased out. Now one may ask, well, why not just measure insulin? Right? And so this has been looked at extensively. About close to now 20 years ago, the ADA, the American Diabetes Association Task Force, was trying to standardize insulin assays because of the disparate results. And the reason for the pitfalls are multiple, but I think the crucial ones to remember here are individuals who have circulating anti-insulin autoantibodies, which would render the assay really uninterpretable, and then, of course, reactivity of individuals who are on exogenous insulin, so rapid or long-acting insulin analogs, which patients use the recombinant versions of these, make it difficult to assess insulin accurately. Finally, not all insulin assays are the same. So not all insulin assays have acceptable performance characteristics that are needed for large-scale population-wide clinical use. And the work from the ADA, the work concluded that not all commercial assays were able to measure insulin with acceptable precision, accuracy, and cross-reactivity, which again makes it a problem when we're assessing things at a population level. So in summary, there's clearly a need for individualizing therapy in diabetes. Assessment of insulin secretion is crucial in patients where the available clinical presentation of diabetes is not so clear. And I hope that the case that I presented today hopefully gave you an impression that this can be a little bit of a confusing picture in a lot of patients. C-peptide can be used as a marker of insulin secretion, but as you can see, there are some pitfalls and some limitations. But on an individual basis, this may have some utility for sure. Sadly, we still need a lot of harmonization when it comes to insulin assay platforms, but definitely we are moving in the right direction for, again, population-wide recommendation. And most importantly, we're hoping that accurate and meaningful laboratory assessment will improve and optimize patient care in diabetes. Well, I hope you learned a lot about diabetes, and I hope you understand the role of C-peptide in insulin assay in these patients. Thank you.
Thank you, Dr. Rao, for that informative presentation. It's time for Q&A. If you have a question you'd like to ask, please do so now. Just click on the green Q&A button at the lower left of the presentation window, type your question into the box that appears on your screen, and click on the send button. We'll answer as many of your questions as we have time for. If we are unable to get to your question, Dr. Rao will follow up with you via email after the presentation. Let's get started. Our first question is, are there other conditions besides diabetes where measurements of insulin and/or C-peptide may be helpful?
So it's a great question. So C-peptide and insulin measurements actually have a role in other disease entities that are probably outside of the diabetes realm. I think the fundamental place where we use it a lot as an endocrinologist is in the workup of individuals who don't have diabetes and are having problems with low blood sugars. So they have hypoglycemia. And what we're trying to figure out is whether these individuals have excess insulin from a source in their body, such as what we call an insulinoma, which can happen very rarely. And what's helpful in the paired measurements of C-peptide and insulin is that we can hopefully distinguish where this problem is coming from, whether it's endogenous insulin secretion or dysregulated endogenous insulin secretion, so again, like I mentioned, an insulinoma, or potentially if it is related to somebody, unfortunately we see this once in a while, what we call fictitious disorders, people who are injecting insulin in trying to gain attention from the healthcare personnel. There, the C-peptide insulin levels would be very informative, along with other screens to see what's in their circulation. So that's, I guess, the hypoglycemia condition, or the low blood sugar condition without diabetes would be a place where this is evaluated and needed, both the C-peptide and insulin assay. Very good question.
Thank you for that answer. We're going to wrap up with just one more question, and that question is, do you typically measure C-peptide and insulin levels on all of your patients prior to treatment for diabetes?
Yeah, that's also a very good question. Again, a population-wide type of question. I think it's very difficult to assess these assays for each and every individual. Clearly, an example of this entity is probably the case that I presented. I think when there's any question of the diagnosis, and I'll be honest with you, you're fooled a lot about people who you think have clear-cut type 2 diabetes, but might have one of these sort of atypical forms of diabetes, or even have actually type 1 diabetes. I think there, the C-peptide level is helpful in garnering which way to go with things. There have been people who have utilized paired insulin and glucose measurements as an indicator of circulating insulin resistance. But as I already spoke about in the talk, I think one of the problems is the standardization of insulin assays, and probably more importantly, is capturing individuals at the point of diagnosis. Unfortunately, even though we have large-scale evidence that shows the levels correlate with downstream events, it's still hard to recommend that at a population level. But clearly, the C-peptide level has an active role, and we utilize that on a day-to-day basis when we're trying to assess endogenous insulin secretion in individuals with diabetes.
I would like to once again thank Dr. Rao for his presentation. Do you have any final comments?
Well, I hope everybody enjoyed the talk, and I think the most important thing here is helping our patients. This is a disease that's growing across the world, as I mentioned earlier, and we really need to figure out ways to individualize therapy. We have a lot of pharmaceutical options in this disease entity. We have to do a better job of making sure the patients are healthy, walking, keeping themselves exercising and active. But we also have a lot of work to do to individualize therapy for patients. So hopefully we're going to move in the right direction, and hopefully you learned a lot from this talk. Thank you.
Thank you once again, Dr. Rao. I would also like to thank LabRoots and DiaSorin for making today's educational webcast possible. Before we go, I want to let everyone know that today's webcast will be available for on-demand viewing through January 13th, 2018. You will receive an email from LabRoots letting you know when this webcast will be available for replay. Please share that announcement with your colleagues who may have missed today's live event. That's all for now. Thank you for joining us. We hope to see you again soon. Goodbye.